Thank you for joining me. My name is Chris Burke. I am a pharmacist here on the clinical team at Aegis Sciences Corporation. I'd like to welcome you here today for this educational presentation discussing new additions to the Aegis behavioral health testing menu that are effective this month, June 2025. Today, we'll be discussing the indications, pharmacology, place in therapy, and importance of testing for these 5 new additions to our behavioral health testing menu. These medications are lemborexant, viloxazine, lumateperone, benztropine, and trihexyphenidyl. To begin, we'll first discuss 2 very similar medications, benztropine and trihexyphenidyl. It is important to note that drug-induced Parkinsonism and tardive dyskinesia are 2 examples of the extrapyramidal side effects that are caused by antipsychotic medications. Drug-induced Parkinsonism, or DIP, is a condition that resembles Parkinson's disease, characterized by tremors, rigidity, and slow movements. DIP often appears soon after starting antipsychotic medication, and anticholinergic medications like benztropine and trihexyphenidyl are generally effective at lessening these symptoms. Tardive dyskinesia, or TD, is a condition that is characterized by involuntary abnormal movements, typically of the face. In contrast to DIP, TD usually appears after prolonged exposure to antipsychotic medication, and anticholinergic medications are often reserved for cases that do not respond to other therapies first, as there is a chance of worsening TD with these medications. Benztropine and trihexyphenidyl have the same mechanism of action in that they function to block muscarinic acetylcholine receptors. In doing so, these 2 medications counteract some of the deleterious motor effects caused by antipsychotic medications. There is a potential for misuse associated with these medications owing to their indirect actions as dopamine receptor agonists in the limbic system. The lack of specificity for any particular muscarinic receptor subtype contributes to their wide range of side effects. Benztropine and trihexyphenidyl are commonly used to manage drug-induced Parkinsonism and may be started as a preventative measure at the initiation of antipsychotic medication before symptoms of DIP develop. The duration of therapy for anticholinergic medications in the treatment of DIP can vary, with some individuals requiring short courses, but others requiring prolonged or indefinite therapy. These medications have many side effects that are worth reviewing. They can have a negative impact on cognition, especially in elderly patients. They can cause blurry vision, dry mouth, constipation, and urinary retention. And as mentioned, they can worsen the symptoms of TD. So monitoring for development of TD is paramount to ensure ongoing appropriateness of therapy. While not common, it is possible for these drugs to be diverted and misused. Trihexyphenidyl is classically considered to be the agent with higher abuse potential. Benztropine is available in an injectable formulation for use in acute care settings, which could be associated with abuse as well. Symptoms of abuse might include hallucinations, agitation, confusion, delirium, tachycardia, and hypertension. There can be a withdrawal syndrome associated with cessation of chronic use. So, why should we test for benztropine and trihexyphenidyl? While not scheduled as controlled substances in all regions, both have a recognized potential for abuse. Users may seek them for their euphoric and hallucinogenic effects, particularly at higher doses. These agents are crucial for managing debilitating side effects caused by antipsychotics. If a patient is experiencing worsening EPS, a test can confirm if they are taking their prescribed medication. Non-adherence could lead to significant discomfort and functional impairment. and both medications have potent anticholinergic effects. Overdose or interactions with other anticholinergic medication can lead to a potentially life-threatening anticholinergic syndrome. Peripheral symptoms could include dry mouth, blurred vision, urinary retention, constipation, tachycardia, and hyperthermia. Central symptoms could include delirium, confusion, hallucinations, agitation, psychosis, memory impairment, coma, and seizures. Next, we will discuss lemborexant, which was first brought to market in the U.S. in 2020. Lemborexant is approved for the treatment of insomnia in adults, including elderly adults. Lemborexant works by blocking orexin receptors that are located in the central nervous system, which results in suppression of inappropriate wakefulness and promotion of sleep transition and maintenance. Lemborexant has a quick onset and prolonged duration of action, allowing it to be effective throughout an entire sleep period. There are numerous potential drug interactions with lemborexant, which are principally mediated by the CYP450 isoenzyme system, so ongoing surveillance for drug-drug interactions is of utmost importance. Individuals taking lemborexant should be counseled to avoid alcohol intake, as alcohol increases the effectiveness of this medication. Lemborexant is the second medication in the dual orexin receptor antagonist class to be approved for use. When compared to traditional hypnotics like benzodiazepines and the Z drugs, such as zolpidem, S-zopiclone, and zaleplon, lemborexant has lesser concerns about abuse, tolerance, and next-day impairment. In long-term trials, lemborexant demonstrated sustained efficacy over periods of up to 6 months, with significant benefit for sleep onset and sleep maintenance. In general, lemborexant is safe and well tolerated, with most adverse effects found to be mild or moderate. The most common adverse effect identified in clinical trials has been somnolence, which was found to be dose-dependent. However, this did not extend to next-day morning somnolence, which is a significant advantage over older therapies. There were also fewer balance problems and less impact on cognition in older subjects when compared to zolpidem. Lemborexant has been classified as a Schedule IV controlled substance by the DEA, reflecting its lower potential for abuse and misuse compared to medications placed in Schedules II or III. The lack of physical dependence or reinforcing effects in preclinical studies, as well as the lack of rebound insomnia, are thought to contribute to this low abuse potential. Lemborexant should not be used in individuals with narcolepsy, should be used with caution and at reduced doses in individuals with hepatic impairment, and lacks substantial data to support its use in pediatric or pregnant patients. So, why should we test for lemborexant? Since lemborexant is a controlled drug, testing can help monitor for potential misuse or diversion, especially in patients with a history of substance abuse. For patients prescribed lemborexant for chronic insomnia, testing can confirm that the patient is taking the medication as prescribed. This helps providers assess treatment effectiveness and address non-adherence if the patient isn't responding well to the medication. Lemborexant is a central nervous system depressant. Combining it with other CNS depressants like alcohol, opioids, benzodiazepines, or other sedatives can significantly increase the risk of serious side effects, including excessive sedation, respiratory depression, and complex sleep behaviors like sleepwalking or sleep driving. Drug testing can help identify if a patient is using other substances that could dangerously interact with lemborexant, even if they have not disclosed this use. Next, we'll talk about lumateperone. In 2019, lumateperone was approved by the FDA for the treatment of schizophrenia in adults and was formally introduced to the U.S. market in 2020. Later in 2021, lumateperone gained an indication for the treatment of depressive episodes related to bipolar I or bipolar II disorder in adults when used alone or in combination with another agent like lithium or valproate. Lumateperone is an atypical antipsychotic with a unique mechanism of action. Lumateperone works by selectively blocking certain serotonin and dopamine receptors while also enhancing effects at others. This combination of actions at various dopamine receptors allows for more efficient dopamine modulation compared to most other antipsychotics. Serotonin transport inhibition provides an effect similar to serotonin reuptake inhibitors, also known as SSRIs, contributing to the antidepressive effects of lumateperone. Lastly, glutamate pathway modulation contributes to efficacy in treating cognitive impairment and various negative symptoms associated with schizophrenia. Potential advantages associated with the use of lumateperone are thought to be an extension of its unique mechanism of action. These advantages include a lower likelihood of drug-induced movement disorders like DIP or TD. There is also thought to be a lower chance of drug-induced metabolic disorders like weight gain and potentially diabetes. Lastly, there is a lower degree of sedation associated with lumateperone compared to older antipsychotics. Given these potential benefits, lumateperone may be helpful in patients who are sensitive to side effects or those who have responded poorly to alternative medications on initial trials. There is not thought to be a significant potential for abuse or misuse with lumateperone, with no significant rewarding effects or euphoria induced, and as such, it is not a federally controlled substance. So, why should we test for lumateperone? For individuals with schizophrenia or bipolar disorder, consistent medication adherence is crucial for managing symptoms and preventing relapse. Testing can objectively verify if a patient is taking their prescribed therapy, helping clinicians understand why a patient might not be responding to treatment or if they are experiencing a relapse due to non-adherence. Although lumateperone is not a controlled substance, monitoring for its presence can still be part of a broader drug testing strategy. This helps to ensure that the medication isn't being diverted or used inappropriately, and it can also identify the co-use of other substances that might complicate treatment or pose health risks. If a patient experiences unexpected or severe side effects, or if their symptoms of schizophrenia or bipolar depression don't improve, testing can help confirm adherence and rule out the influence of other substances. Lastly, we'll talk about viloxazine, which is a medication that was first brought to market in the US in 2021 after it was redeveloped into an extended release formulation. The initial approval for viloxazine ER was for the treatment of ADHD in children and adolescents. In 2022, viloxazine ER was granted an additional indication for the treatment of ADHD in adults. Viloxazine has a unique mechanism of action whereby it modulates multiple neurotransmitters in the brain. Primarily, viloxazine works by preventing the reuptake of norepinephrine, thereby increasing extracellular concentrations of this neurotransmitter. Viloxazine also modulates serotonin pathways, directly acting at various receptor subtypes, improving mood and cognition in those with ADHD. The primary role for viloxazine in clinical practice is as a non-stimulant option for those with ADHD. This can be particularly useful in patients who cannot tolerate stimulants due to unwanted side effects, or those with a history of stimulant abuse. Viloxazine is not thought to have the potential for misuse or abuse, and as such, it is not a controlled substance. It has not been shown to produce euphoria or pleasurable effects, even in those with a history of drug misuse. So, why should we test for viloxazine? For patients prescribed viloxazine, drug testing can confirm if the medication is being taken as directed. This is crucial for ensuring the patient is receiving the intended therapeutic benefits. Conversely, if a patient is not responding to treatment, testing can reveal if they are not taking the medication or if it's being diverted. While viloxazine has a lower potential for abuse compared to traditional stimulants, this could still be a consideration in some contexts. Viloxazine is known to have significant drug interactions. It's a strong inhibitor of CYP1A2, an enzyme responsible for metabolizing many other drugs. Since viloxazine is not a stimulant, testing can help confirm that a patient is taking the prescribed non-stimulant rather than a stimulant, particularly in settings where stimulant use is monitored. Each of these 5 new additions will be available for testing in urine or oral fluid. In summary, this behavioral health testing menu update reflects our ongoing commitment to helping you make a difference in people's lives. We do this by providing clear, reliable, and actionable information on patients' medication adherence that helps providers deliver the best care. I would like to thank you for attending this presentation today. If you need further assistance with any clinical questions, please do not hesitate to reach out to the Aegis clinical team at the phone number or email address listed here on your screen. Thank you.